Okay, good evening. First, I'd like to thank everybody for inviting me here and accepting to hear my presentation. It's about some work I did started 2 years ago and still ongoing till now. So it's about using utility of whole exome sequencing in early diagnosis of pediatric-on-set cerebellar atrophy associated with developmental delay in an inbred population. So cerebellar atrophy and developmental delay and intellectual disability are associated with a large number of genetic diseases, and there is a heterogeneous group of genetic conditions associated with these disorders, and they have overlapping clinical criteria. And unfortunately, the MRI and the neuroimaging features are usually not very specific to reach a specific diagnosis. Therefore, we found out that finding new specific tests, specifically genetic testing, would be of vital importance to reach the diagnosis. The aim of the study was to investigate as much as possible the genetic background of cerebellar malformation associated with developmental delay in children. We mainly focused on cases without a specific known diagnosis. And up till the end of the first year, we were able, by using whole exome sequencing, to identify about 50% of the disease-causing genes in the families. Some of these families were consanguineous, but the disorder were belonging to autosomal dominant mutations. The MRI classification has about like 6 features which can be seen on MRI. The first 3, according to the literature, usually belong to malformative disorders. So we mainly put in the panels or focus on the genes that play part in the cerebellar formation and the cilia formation. The unilateral cerebellar atrophy is usually reported with perinatal or prenatal injury, while the global cerebellar atrophy and signal abnormality usually are associated with respiratory chain disorders. Other common causes of cerebellar atrophy in children are mitochondrial disorders, NCL, disorders of glycosylation, ataxia telangiectasia, and infantile neuroaxonal dystrophy. The etiology of the cerebellar atrophy is not known specifically, but we believe that Purkinje fibers play an important role because they're the only outcome of the cerebellum. And up till 2015, there were about 196 reported disorders with developmental delay and cerebellar atrophy. But all of these disorders still don't have a specific genetic disease that we can directly test for to confirm them. The study was carried on, it started 2 years ago, and it's actually an ongoing study, so we're still assessing samples and analyzing samples, but I'll give a report on the first and second years. So in the first year, we had about 21 families, 12 of them were sporadic, all had MRI to confirm the cerebellar affection. We did all the possible neurological and clinical examination and biochemical testing. And half of these cases, we did whole exome sequencing for just the proband, while the other half we did tri-sequencing involving the parents, and sometimes we added another affected child if he or she were available. As I said before, the clinical features are usually not specific. It starts with motor and cognitive delay. Some of the features actually appear after several years, especially disorders like iron accumulation in the brain. So by identifying the molecular disease-causing genes, this allows us to diagnose the cases pre-symptomatically and either provide some treatment or intervention or at least counseling. Again, this emphasizes the importance of the whole exome sequencing in those unknown disorders. The method, I won't go deep through the method because this is kind of more of bioinformatic personnel, but we did the whole exome sequencing using the Illumina HiSeq 2500. The depth of the coverage was approximately 160x, and more than 97% were at least covered by 30x. And we, as I said, we proband the sequence for the proband for half of the cases, while the other half we did tri-sequencing. We had a variant filtering pipeline to try to filter out the highly suggestive or prioritize the variants that come out from the data. Of course, we chose the functional variants, removed all the common variants, and we looked in more depth on variants which were pathogenic by SIFT and polyphen-2. And at the end of each test for each family, we usually confirm the diagnosis by doing Sanger sequence for the suspected gene. These were the results for the first year, most of the cases in the first year, and 50% of them we were able to identify the disease-causing gene and confirm it by segregation and sometimes some other biochemical tests. I will not talk about all of them, but I'll focus about some of the interesting genes. 6 of the genes were actually previously reported, so they were not reported as novel genes. And the PLA2G6 gene was found to be very common in our population. It's associated with neurodegeneration and iron brain accumulation. And actually, we had in the first year about 50% of the cases that were analyzed in the first 9 months to have this mutation. And by the end of the second year, another case appeared. So all in all, in between 40 cases, we had 4 cases with the mutation, the PLA2G6, which actually, I'll say that it's before, but which actually made us think that it's better to Sanger sequence all the cases that we collect for this genetic disorder before going to whole exome sequencing, just to save us money of whole exome sequencing if we can find out the mutation in the PLA2G6 from the beginning. And this is the first case. As you see, most of the clinical symptoms are not specific, hypotonia and deterioration and weakness. Of course, there are cerebellar ataxia and cerebellar signs and symptoms. Most of the cases, if not all, had epilepsy. They were treated with anticonvulsants and some brain tonics. And in most of the cases, the ammonia and lactate, which is kind of a routine biochemical workout that we do to most of these cases, is usually returns to be normal. The whole exome sequencing showed that a few genes were susceptible, but by doing the segregation with the parents, it turns out to be the PLA2G6 gene. This is another case, again, with the same mutation, the PLA2G6. There were 2 affected siblings, and again, non-specific clinical features. We pulled together, this is a pool of 3 families just to show the mutation by Sanger sequencing, where we can see in the first family we have three normal siblings, and the last one, 11EA, he has homozygous mutation deletion in the PLA2G6 gene. And the second family, the two parents are heterozygous, while the two children are affected, as I showed in the previous slide. So the PLA2G6, it plays an important role in the neurodegeneration of iron brain accumulation. And actually, this gene doesn't play a role in iron metabolism, but the mutation causes accumulation of iron in the brain, especially in the basal ganglia, which causes most of the symptoms and the spasticity. We offer now prenatal diagnosis for this gene in these families, and also we've started trying iron chelating agents that cross the blood-brain barrier, and the cases that started it at early age showed a mild improvement and slow deterioration in the case compared to those who didn't take the iron chelating agent. It has been reported previously that there's a founder effect for this gene in North African foundations, so maybe that's why we see a lot of this genetic disorder among our cohort. And actually, 30% even by whole exome, and there are no genetic mutation identified, and maybe other genes may be identified by either using whole genome sequencing to uncover the reason behind these 30% of the cases. This patient, she was 3 years old and 8 months when we collected the sample. By the time we finished, she was 4 years old. She again had the global developmental delay. The MRI showed frontal subdural hygroma, and she had epilepsy. And at the beginning, her condition was very severe. The segregation showed the whole exome sequencing identified the MOCS2 as the most suspected disease-causing gene, and the segregation actually confirmed this gene to be the cause behind her problem. And as we see, both mother and father are heterozygous. And she has 3 other siblings. 2 are, the first row is the normal sibling, but he's completely normal, and the mother and father are heterozygous. The fourth shows the proband, and she has homozygous deletion. And the last row shows the other sibling who is a carrier as well. So as you see, the whole exome sequencing gives us information about carrier status of her sibling, her brother and sisters. This mutation of the MOCS2 plays a role in molybdenum cofactor deficiency, and it's a severe inborn error of metabolism, usually associated with early neonatal death, and it's lethal. But in our cases, the child started to improve, and we correlated the subdural hygroma to be a mild form of the disease because pathognomically this disorder is associated with multicystic disorders in the brain. Her biochemical tests came to confirm the diagnosis with sulfite oxidase and plasma xanthines to be sky high. And the mother was pregnant in another child, and we offered prenatal diagnosis and identified the child, the new baby to be affected, and we gave her counseling, but she never came back, so we don't know her decision after that. This family Again, all the symptoms of cerebellar affection, the ammonia and lactate and biochemical tests came normal. We even did karyotype because he was a little bit dysmorphic but was normal. Whole exome sequencing identified the RRP8 to be the disease-causing gene and was confirmed in the whole family. Both parents are carriers, and one of the siblings is a carrier and the other is completely normal. And this family, again, a normal karyotype, typical cerebellar affection symptoms, epilepsy. Whole exome sequencing identified two genes to be susceptible, and when we did the Sanger sequencing, the disease segregated with NTRK3 gene. The last family, again, the only specific clinical criteria were optic atrophy and hearing loss. And by whole exome sequencing and segregation, we identified the FDXR. And according to the literature, this plays a part in auditory and optic atrophy associated with epilepsy. This is to show her MRI, and 3 genes were generated by the whole exome sequencing, the DNA H17, FDXR, and HTT, but only the FDXR segregated. At the end of the second year, another 2 families were identified. They're not new genes. One is ceroid lipofuscinosis gene. Again, this is turned out to be quite common in the Egyptian population. And the other one is a de novo gene, which is usually associated with cerebellar atrophy and epilepsy. In the second year, the cohort reached 40 patients. Not all of them we have the data for, but these 4 cases were confirmed by Sanger after the whole exome sequencing, and one of them was confirmed also by buccal smear for ceroid lipofuscinosis. And they all, apart from 39, which is, 38, which is a new candidate gene, and we're starting to do functional analysis for them. So my conclusion is the whole exome is a quite important test to identify non-known diagnosed cases with cerebellar atrophy. It also offers prenatal diagnosis and carrier detection in the families and relatives.